Welcome to the Rehab Remix.
Where we break down the hottest topics in ortho and neuro PT to help you elevate your clinical game. We're your hosts, Dr. Lauren Tighe
And Dr. Lauren Young, bringing you practical insights straight from the evidence to your earbuds.
Hey, welcome back. In part one, we got to hear about your personal journey into risk management and why it's such a critical but often overlooked part of PT practice. Now, in part two, we want to shift gears into the real world takeaways in terms of what risk clinicians actually face, what habits protect them, and how PTs can think differently about career opportunities in this space. What are the most common risk management issues you've seen in clinical settings, especially for new or early career PTs?
It's a good question. I think it really kind of depends on the setting, the type of issues that are arising, and then what the impact is, whether these are liability claims or they're licensure issues or their reputational impact. And I think far more than liability claims, there are just patient complaints or unsatisfied patients or poor outcomes, and it eats up a lot of time in figuring out how to best manage the relationship between the therapist or the organization and the patient, because the reputation really matters. So if we're talking about outpatient, your clinic is in a local community, these people may live there for years, your potential client or patient is going to be around in that area for a long time likely. So having a strong reputation is very important, and how you manage those situations, meeting those head on, is important. I think some of the more common, things that come up that get therapists in trouble are a failure to identify that there's been a change in condition and making communication back to a referring provider, or recommending that they go to the emergency department. We've got informed consent issues, which don't always end up in a claim or a lawsuit per se, but they end up in he said, she said of, you never told me that this wasn't going to work, or that I could get a punctured lung, or that I could fall doing this, or that I was working with a therapist assistant, or whatever it may be. I think a lot of these situations, you want to be having open conversation and communication. And then the other big one is, I think, therapists kind of failing to input their clinical reasoning into their documentation. So the biggest takeaway from we could do an hour on documentation itself easily, but the biggest takeaway, just to keep it brief on the documentation end, is documenting your clinical reasoning. Because if you've got a reason why there that makes sense for why you did whatever you did, and you've got other aspects of the note that are undone or not great, having the clinical reasoning there really can make up for a lot of shortcomings in other areas. So I think that's really important. So I guess I would say those are a few things that tend to come up. Falls is always a big one, right? And whether or not you could prevent it. A lot of times they're not preventable, but it's what you do afterward. Did you make a thorough assessment? Did you make communication to either the patient or the family or the referring provider back to the PCP, or did you check on them a couple days later? And their settings independent too,
Yeah. And that can be like a really scary experience too, initially for a fall. I think back, and this is hand to God, the truth. One of my very first jobs, I had a patient who had no signs of diabetic, like shock symptoms, anything like that. Like I knew that they had a history of diabetes controlled by medication. Like I had seen them several times. And then in one session, so like I would put him on the upright bike, everything. And we had done this 100 times. I mean, like if you went back in the notes, like that's what we did, because we were trying to work on some mobility in the knee, right? So one time he went into diabetic shock on the upright bike and fell over, because and it's natural practice almost in the clinic to put somebody on a bike, either turn your back and go get your stuff and come back, or walk away, whatever. And I had like one of those rolling desk things, right? So I wasn't that far away from them, but I was not close enough to catch them, right? So it was just like watching dominoes fall. And like everything you're saying, I'm just so thankful that I had the supervisors and the leadership that I did in the clinic that I worked in, because everything you're saying is what they did. Like immediately we responded, obviously. Like it was something that happened so fast, and like I couldn't prevent it. There was no signs. I constantly checked every visit to say, hey, like, how are you feeling? Did you take your medication today? Are you dizzy? In between every single exercise, right? And so it was just like every other day. And then I was in like panic mode. I'm like, oh my God, I'm going to get fired. My license is going to be taken away. But all the things you said to do, like call and follow up with them, make sure that they were feeling okay. Like, and I had already built a really good rapport. And I vividly remember the patient saying, "Oh my gosh, it is not your fault. It is my fault. I didn't eat enough before therapy. You are constantly checking on me. You're constantly reminding me." And they were like, "I just honestly felt silly. Like it had nothing to do with you. Like I was embarrassed." And I was like, and nothing, and obviously like they were fine, like no injuries, maybe a couple bruises, but like outside of that, in that moment, it is literally terrifying. And so for to hear you like recommend all these different things like in our part one, I think back to like, wow, like I'm so glad that I had that leadership that knew what to do because I certainly didn't. Like that is just not something that I was aware of. So I think just like in you talking about the things that are most common, like a fall, I'm like, yeah, well, I experienced that. And that can be really traumatizing and it can be really, really scary as a new grad.
I think, in that case specifically, like very simply, what we talked about there in the clinical reasoning and how that matters is if you had that patient and for the 5 previous visits that you had with him, he was able to do 5 minutes or 10 minutes sitting unsupported and doing that bike and there was no problem. And then that happens and you write in that note, therapist with patient on the bike, as did in the previous 5 sessions. Patient had demonstrated, independent with trunk strength, whatever it may be. But if you just pop a little note in there of the reason why it made sense, you're pointing to how this probably wasn't preventable and you didn't fail on your duty to provide safety to the patient because he had already done it, or we knew he had good enough strength. And it's very similar to like the ambulatory gait training cases, right? Like we knew he could, he happened to have a fall, tripped over his foot, but he had already done 5 sessions where he was walking with this cane and had, it had progressing steadily. So there is reason why you did what you did that proves it probably wasn't for your failure as a therapist that this event happened.
And Mike, I've been seeing on your Instagram where you talk about like AI documentation. And correct me if I'm wrong, but I feel like what I've seen, you're seeing clinicians who are just leaning on this AI documentation and not putting their clinical reasoning in their notes. And so that's a big red flag. And I use an AI scribe, but I tell it my clinical reasoning and I make sure it gets into the note. But is that something that you're seeing with the use of AI? Because we're not talking out loud typically by the patient, like, oh, we're going to do this because of this. You keep it in your brain.
Yeah, and I think absolutely one of the biggest concerns is skill degradation, right? If you're not doing it, if you don't do it, then you lose it. I think all the major organizations are going to be using some form of ambient scribing to help with the documentation process because you're going to have difficulty retaining staff if they know, hey, I'm doing my documentation in a minute and a half, I sign off it. But to answer your question or talk about your thought there is that if you are obligated, if you've signed and stamped that note electronically that you agree with whatever, there's no real going back on that and say, oh, I didn't look at it. Nobody really cares. Like in a claim that comes up, that just doesn't hold up. You get an expert to review the case and say you signed off on this note, and you can say that the ambient scribe made a mistake, but you are obligated to review that note and make sure it's accurate, and you're putting that stamp on it, your signature on it in that whatever EMR system you're using. So it's very important for a couple of reasons. If you read it and you know what's going in there, you can try to avoid decreasing or diminishing your skills in how you document, which is going to be important in terms of the review and the clinical reasoning and putting all those pieces together. A lot of times we remember because we're documenting and we're generating that thought to document. So when we go to see the patient next time, our clinical reasoning is a little bit more intact in terms of how we go about it. But I think overall, you really need to make sure that you're reviewing that and you're putting your stamp on it because you own that.
This is such an interesting conversation because I do see, in the clinic, I don't work a ton with other people now that I'm a solo practitioner. But what I've seen, just teaching some continuing education courses and talking to other therapists is that have had students more recently than I have is kind of this loss of being able to either one clinically reason or whoever the clinician is able to clinically reason. But then, like you're saying, there's no documentation showing that. So if there's an audit or something, insurance isn't reimbursing because somebody that's unskilled, a tech, an aide, whatever, could come in and do the same thing that the therapist was doing, because we're not talking about our skill. We're not talking about what's next and why we're
Yeah.
doing what we're doing, which I think is also part of the reason we're seeing reimbursement decline and seeing other practitioners say, well, I can do what a PT can do, because we're not saying those things.
Yeah, I think you're 100% right. Like, you got to prove why. The people who are paying want to know why they're paying you, and why do I have to pay you, and why can't I pay someone of lesser skill? And then you've got to demonstrate that what you did met the standard of care, and there was some good reasoning behind what you did. I think for a couple different reasons. But one other thing I would say is that a lot of times we get very used to seeing the same type of patient, and we make the same recommendations in terms of education, but still put that in there because I think I did a little talk about this some other place, but basically, it may be your patient's first time ever hearing that. It may be rudimentary to you. You may think, oh, geez, I do that with everyone. But that may literally be the skill that is the difference between the insurance company saying, okay, good to go. That's something you learned in school. Your license, it makes you an expert in that, and that's in there. And now we're paying. So don't be afraid to put those small pieces of education that seem like no brainers, because they're not no brainers to everybody.
And in the EMRs these days, you have all these smart phrases and quick phrases. If it's something that you do all the time, just quick phrase it and get it in there. If there needs to be a change, like you
Yeah.
said, to make it specific to that individual, do it. But like, there's so much now that our documentation really, from when I started being a PT to now, could be 10 times better if we use the tools correctly. I just don't know that we're all using the tools to their fullest potential.
Yeah, and don't get me wrong. When I was a therapist, I hated doing this long document, especially because I was always so concerned with getting the full picture of the reasoning, that I was not good at that. I was not good at managing time around doing the notes and doing them point of service. I was terrible at that. Me more than anybody wanted a streamlined process for documentation. So I think we have to be at least aware and reasonable about that too. So I think good point there.
Like, one other question, because I've seen this on your Instagram as well. If you're not following, Mike will tell you where to go find him later. But if you're not following him, go follow him, because like the clinical pearls that I'm getting off of this, and it's one of the things that you said, informed consent. So everybody signs paperwork at the beginning saying there's a risk of falls, there's a risk of this. You might get better, but also we could make it worse depending on the situation, if it's pain or whatever we're looking at. You're saying that we should have them sign that at the beginning, but then before we go to a riskier or a treatment with more risk, maybe I should say that, we consent them again and then document that?
I'm saying informed consent is a process, is not a document. You have a document that solidifies the fact that you've had the conversation and given them the process. But if there's a couple quick takeaways, so you don't have to become an expert on this, but just think, if you're doing something to your patient that you think may increase their risk of something else, so think of cervical manipulation or dry needling, or thankfully we don't do a ton of super risky things in therapy, right? But at the very least, have that conversation of what the expected outcomes are. And if it's something that's increasing the risk, it's probably something your clinic should have a form on. So to basically to quickly put it, informed consent is not a document. It is a process where you're talking about the risks, the benefits, the alternatives, and the expected outcomes. If you have a good conversation with your patient and you tell them what you expect to come from this, and keep in mind that they are the boss, they make the decision, you make your expert recommendation to them, and they decide, then you're far less likely to have someone coming back a month later and saying, I thought I was going to get this. You told me I'd be able to walk. I thought my pain was going to be completely gone. Why did I go through this needling, and now my pain is worse? Let them know not everybody has the same, experience with it. Just have the open conversations, and you have a lot less dissatisfied people, a lot less claims and complaints.
That's beautiful. One thing that I remember in my practice was the standing frame with someone who has a chronic spinal cord injury. It's typical to get in the standing frame after you've had a spinal cord injury. It helps with bone density, blah, 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 typically acutely. But then we're getting these people who have chronic spinal cord injuries, which means most likely their bone density has decreased. And so they're at a higher risk for a stress fracture. Then we talk about women who are postmenopausal, who are at higher risk. I had a form that I told them, you want to get in the standing frame. I don't think it's a bad idea, but here are the risks. And we would go through, what are your risk factors? Well, the fact that you've had a spinal cord injury for more than 6 months, the fact that you're a woman who's postmenopausal and you're already at risk for osteoporosis. That way, if something did come up, it's documented. We've had the
That's incredible.
conversation. And there's been times that I've had people go get DEXA scans. I would tell them the risk and they're like, well, I don't know. And we'd go back and get DEXA scans. But these are things I think the other piece of this, you have to know the risks, right? If you're not versed in working with people who have spinal cord injuries and don't know that that's a risk, then you set yourself up for liability
Oh, you're
issues.
obligated. If you're providing a treatment or performing something on someone, you need to know what potentially could go wrong, even if it's very rare. And you really should have some general idea of what the incidence rate is, But that's incredible. I'm not familiar with what you were talking about that, and you were doing that. That's right on. That's right in the wheelhouse. That's
It,
excellent.
and it's, things that you learn from just doing this time and time again and being in it. So I guess that brings me to kind of our wrap up question. But when you look back at your career from what you know now, if you could go back with your 2020 vision, what would you do differently as an early career PT or PTA? It could be OT, any therapeutic discipline. What would you do differently to kind of mitigate your risk?
It's probably not the answer you're looking for in terms of mitigate the risk, but I think I may have worried a little bit less about getting sued about certain things, like knowing that like you really kind of need patient harm to get sued for something. So I think in certain situations I probably would have worried a little bit less. I think overall I may have tried to explore a little bit of what's out there, not to transition out of clinical care, because I think the clinical care is important. I think it's good to know if you're in school and you got this uneasy feeling and you're in, year 3 or 2, and you're like, geez, I don't know if I'm really, cut out for direct patient care, like, because there are those people. But I think that getting into the patient care is really great and should be done for a few years, because I think it's invaluable. But I think just being open to the idea that there are other things that you can learn or do, even if they are using your degree or in your clinic, but be open to having a conversation with someone to say, hey, like I still want to treat PT clients, but I've got an interest in learning this. And you never know, whatever leader of the organization or business that you're at, what they might be open to, if you can present them an interesting idea that makes sense for them too.
Love that. Our last question that we really like to ask our guests each episode is, what is your personal rehab remix? So maybe a unique habit, a hack, or a mindset that you use every day in your current role.
Currently, because I'm business owner now, so I think it's just moved the needle every day, because you get inundated with things that come from different angles. I think this can relate for students too, or people in their everyday life. You get so much going on, you don't know what you want to grasp onto to really spend your time and energy in. So sometimes having a schedule can be important, but just trying to move the needle, like just keep moving, right? Like getting something done that you can point to say, hey, yesterday was a shitty day, it's kind of a wash, but I did connect with those 2 people, or whatever it may be. And the last thing I think in general, just for the students, is be open, be open-minded to stepping outside of your comfort zone, because you never know what that'll lead to. Like, I thought I would have been a, PT forever. I loved it, loved the patients, everything. Landed in risk management, got a degree in health law, certification in risk management, and I love doing that too. Love doing this stuff too. So just be open, step outside your comfort zone.
Love that. Just trying to like essentially be 1% better every single day. I love that. That's great.
Yeah.
So thank you so much for being with us for this episode, Mike. We had so much fun talking with you. Before we wrap up, can you let our listeners know where they can find you and follow along with your non-clinical journey and just see all the things that you're doing for the profession in terms of risk management?
Sure. So rehab underscore risk underscore consulting on Instagram. I just fired that up a couple months ago. Just post little videos that are, relative for risk management for clinicians and business owners, but then also kind of some non-clinical stuff. And then I've got the non-clinical rehab network. So for people who, know they want to get a non-clinical job, it's a community that will help take you through the process. And kind of risk management allowed me to kind of see the health system in a lot of different non-clinical jobs. And I'm hoping to help people transition if they're interested. But the clinical work is great too. So not pushing people away from that at all. I think it's great.
Awesome. Thank you so, so much. We really appreciate you being here with us.
That's great. Thank you very much. Hi, guys.
Be sure to sign up for our newsletter linked in the show notes. You can find me, Dr. Young, on Instagram at NeuroElitePT. And Dr. Tighe, where can they find you?
On Instagram as well at LTigheDPT. Thanks for tuning in to the Rehab Remix, where you listen in and level up. We'll see you next time.